Yes, what we do is we have centered all of our work around the customer. And we call our patients customer owners, and we like to make it easy for them to do the right thing. What we try to do is to look at the events that actually occur in someone's life, agnostic of a disease. Because we found when we built disease-centric models of care, what we did was have a lot of redundancy and waste in between each individual diseases if someone should be unfortunate enough to have more than one disease. So what we did was say we want to build the model around the customer with as much sort of centralized access to different sort of specialists. So we have an integrated care team that has a provider, a nurse case manager, a medical assistant, and a clerical assistant, and 5 of those integrated care teams are supported by an integrated pharmacist, midwife, 2 behavioral health consultants, and a dietitian and certified diabetic educator. Now what that does is allow them to accommodate most of the ongoing chronic condition, preventive health, or screening behaviors that any population would need, and they would have a relationship with specialists where they would refer out for things that would be unique or different or changing. Now how we had to incent this is we had to place all of our providers on salary and remove all productivity or RVU-based quotas. And what that meant was, as long as you got a completed list of all of the chronic condition monitored, all of them under control, all the screening done, all the vaccinations done, with good access to both your specialist and your medical home. And for us, we define access as able to make an appointment the same day of your phone call with your medical home provider. If that all can happen, the number of visits per year is less relevant than the outcome of all the collective behavior of those visits. What happened to us is our measured PQRS performance with chronic condition control, screening, vaccination rates, etc., went from the 25th percentile nationally to now mostly the 90th or 75th percentile. Now, our cost went up from 2004 to 2009 only 7% with our healthcare spend. So what we did was remove a lot of the redundant inefficiencies that we were needing revenue to continue to support, and we collapsed what were legacy departments for behavioral health, for pharmacy, for dietitian, for primary care, or chronic condition management into single units that could address all of these things collectively, but more in a relationship with the customer that we serve. It's interesting because we acquire providers as we recruit and hire who come from other systems, and the systems teach them a sort of different approach to the workflow. Now what has happened in the industry is there's a tremendous amount of new sort of incentives, case management fees, things like that. These are often bolted on to the outside of business as usual. What we're really trying to do is, instead of add these new sort of incentivized programs, is to actually shift business as usual to something that looks a little bit more like a lean model. But that's not naturally the trained behavior of many of the staff that come to us from another place. So we actually have to spend a lot of time and investment in the recruiting phase, but also the orientation phase,